Okay, thank you for the invite and online class for tonight. Sorry we couldn't do face to face, bit tied up in the daytime. So hopefully we don't go too long. Depends on how many slides you've got. Okay, shall we begin? Usama, nothing presented. Jadi ada?
We are waiting for the slide to, yeah, okay.
Okay.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So today we from Group C will be presenting Clinical Pathological Conference CPC on acute and chronic pancreatitis, supervised by Ms. Next. Okay, so in this presentation, we will divide into the first one, case presentation, and then acute pancreatitis and chronic pancreatitis. Next. So for the first part, I will be presenting by me, Aina, and my friend Aisha. Okay, so for the case presentation, the chief complaint of this case is Miss A 20 years old Malay lady, presented to the emergency department of HTAA for worsening upper abdominal pain for 3 days duration. Next. Okay, so for the patient history, for the history of presenting illness, the patient Miss A had worsening abdominal pain for does not relate to other parts of the body, and then it was aggravated with eating and not relieved with analgesic. Where she went to clinic kesihatan on day 2 of illness, she was given medication for gastritis and analgesics, but the abdominal pain was not resolved. So she came to EDHDA the next day on day 3. And then there was no alleviating factor. The pain there was no chest pain, shortness of breath, or palpitations. And on further questioning, the patient had denied history of trauma, inside bite, prolonged steroid use, alcohol ingestion, previous endoscopic procedure, especially ERCP, and also any history of autoimmune disease. So for past medical history, she had underlying bronchial asthma, which is well controlled, and currently on a follow-up at KK Paya Besar. So currently she is on MDI salbutamol PRN, and her last asthma attack was last year on March 2022. Next. So for past surgical history, there was no past surgery or surgical procedures done. For drug history, she has no food or drug allergy and no history of prolonged steroid use. And then for family history, she has a strong family history of bronchial asthma. However, there is no family history of gallstone, pancreatic disease, or malignancy. And then for social history, she is single and unemployed, currently living with her parents and siblings. She's a non-smoker and non-alcoholic drinker, and she denied any high-risk behavior such as sexual promiscuity and also intravenous drug usage. Next. So on physical examination, we did physical examination on day 3 of admission, day 5 of illness. So from general inspection, she has a medium body build. She is conscious, alert, oriented, not in pain, not septic looking. However, she had noted scleral jaundice. The peripheries were warm to touch, were warm. There was good pulse volume, and the capillary refill time was less than 2 seconds. So for vital signs, it was normal. Next. So on abdominal examination for this patient, the abdomen moved with respiration. The umbilicus is centrally located and inverted. There was no abdominal distension. There was no scar or dilated veins. And then on palpation, the abdomen is soft. However, there was tenderness over the right hypochondral and epigastric region. However, the other was soft and non-tender. There was no guarding, no palpable mass, no palpable liver and spleen. The kidneys were not palpable and palatable, and then the morphine is also negative. So on percussion, shifting dullness was negative and throat space was also negative. On auscultation, bowel sound was present and normal. There were no other aortic and rosarinian being heard. So for other systems, were unremarkable. Next. Okay, so for summary, Miss A, a 20 years old Malay lady with underlying well-controlled bronchial asthma, presented to emergency department of HTAA for worsening epigastric and right upper quadrant pain for 3 days duration, which is associated with fever and thick-colored urine. Fever, vomiting, and also thick-colored urine. So physical examination reveals scleral jaundice and tenderness over the epigastric and right hypochondrial regions. Next. So that's all for my part. I will give to Aisha for the next part.
Okay, so Assalamualaikum. I'm Aisha. So I will continue with investigation and management for this patient. So this patient was admitted for 5 days. So for investigation done for this patient on day one of admission, day 3 and also day 4. But we
Aisha,
considered
sorry.
yeah.
If before you proceed to the investigation, can we move the slide back one slide back?
Boleh.
Okay. To everyone, so this is a summary, a good summary. What is the from this summary alone? All right. From this summary alone, what is the provisional diagnosis? So you have epigastric pain, hypochondriac pain, you have fever, and you have jaundice. What is the diagnosis?
Cholelithiasis.
I think for the jaundice, right hypochondrial pain and also fever, I was thinking of quite trans.
Apa dia?
For,
Yes. Jangan lupa the triad kan? This is classical You give epigastric pain, right? Hypochondrial pain, I mean, sometimes they are sort of interchangeable or intertwined. But fever and thick-colored urine. So clearly the three components are there, suggestive that this more likely based on the history and examination, going towards ascending cholangitis. Okay, so that should be coming to your mind as the first diagnosis based solely on the history examination. I hope you guys get that point. This presentation is typical of your ascending cholangitis. So I hope that you guys don't say any other differential diagnosis. I mean, you don't give any other provisional diagnosis apart from ascending cholangitis when you hear this kind of history. Okay, I might accept if you want to say apa lagi tadi somebody was saying some other differentials. Give me some differentials that we can accept given this history and examination. Would you consider pancreatitis being your high on the list on your differential? You can, not wrong, but probably lower on the list. Okay, just given the history and examination. But what I want you to take from this here is that when you have a very typical history, you should also be ready with some the differentials that you are very familiar with. So one is your ascending cholangitis. Next is apa lagi? Come on, year 5, year 3 boleh jawab ni. Come on, shout out.
Cholelithiasis.
So obstructive is no, you've gone past that, brother, because dia dah ada fever. It's already cholangitis. So we've gone past that. Kalau tak ada fever, yes, you say memang dia ada cholelithiasis, which has led to ascending cholangitis right now. So we've gone past that. Anything else?
acute cholecystitis, Mr.
Acute cholecystitis, yes, I do. I do accept that. Sometimes we do get fever, right hypochondrial pain, jaundice. Sometimes you can when there is um, what we call the translocation of the inflammation towards the liver. So you may get that, but that is not a common presentation. Therefore, it cannot be as a provisional. It can be the differential. Any other differentials that can give similar presentation, epigastric, hypochondrium, fever, thick-colored urine that you should be thinking of. Because if you have all of these things in your mind, then you know, and it will guide you in terms of what investigation you're going to order. If you're not thinking of those differentials, there will be some investigation that you're not going to order. Okay, so what else?
Hepatitis.
Good. Yes, this can also be a presentation of hepatitis, regardless of the cause. Many causes for hepatitis, correct? But this presentation can also be as a result of hepatitis. Lagi,
Liver abscess.
liver abscess, excellent. So those are the things that I want to hear you guys being able to tell me when you find this kind of presentation. Yeah. So in the exam, kalau kita bagi this kind of scenario, these are your answers. And then pancreatitis can come lower down the list. Because what is the typical presentation of acute pancreatitis?
Acute pancreatitis we have presentation of epi or center
Yeah.
pain
Yes.
with dull or aching in characteristics,
Yeah.
and it's constant, like persistent,
Mhm.
and the like typical feature is the relevant factor that the patient has, like it's called a pancreatic position, or like they lying forward to relieve the pain.
Correct. So epigastric pain that radiates to the back. That's number one. It radiates to the back and relief on lying forward. So that's typical of pancreatitis. Okay. All right. Now carry on.
Next snap.
Carry on. Carry on.
So for the investigation done for this patient on day 1, day 3, and also day 4. So for day 1, the investigation done was a full blood count, liver profile, liver function test, serum LDH, serum amylase, and also coagulation profile. So for full blood count, the hemoglobin on the day of admission, it was 14.6, and then on on third and fourth admission, reduced to 10.9, but she was asymptomatic, not anemic. So for white cell, increasing in trend, 11.34. For platelet, normal. And then for renal profile, there is no derangement in the renal profile. For liver function test, on the day of admission, AST, ALT, and LP increase. And then day 4 of illness, day 4 of admission, AST reduced. ALT still in the increase. For total bilirubin, the decrease in trend. And then for LDH and serum amylase, it was done on day 1st of admission. For serum LDH, it was 446 increase, high. High. For serum amylase done for this patient was 2,254. Three times higher than the normal value, which is normal value for serum amylase is 40 to 140. For INR, normal for this patient. We need to come back next. Okay, Okay, so this patient also done ultrasound of hepatobiliary system. So for the findings, the gallbladder is well distended with multiple stones, accumulatively measuring 4.1 times 2.0 centimeter. But there was no thickening of the gallbladder wall, and also there's no pericholecystic fluid collection. The liver is normal in size and appearance, no local lesion, no biliary ductal dilatation, portal vein pattern. So impression was cholelithiasis.
Okay. At this point, now you can actually change your provisional dah. Because just now, when you first saw the patient, you got the history examination, based on the typical features just now, it seems to be ascending cholangitis. But then now that you've done the blood test, the ultrasound, the blood test did show some form or element of hepatitis and some form of biliary obstruction because bilirubin was raised, right? The white cell was just at the upper limit of normal, yeah, right? In the beginning it was 10.62, right? But the liver function was showing some derangement. And suddenly you got your amylase being 2000, very diagnostic, very pathognomonic. And then when you do the ultrasound, it completely relegate the ascending cholangitis being the provisional. Because why? Why is ascending cholangitis no longer the case here? Despite the fact that blood does support ascending cholangitis. Why, based on the ultrasound, this is no longer ascending cholangitis?
Because there's no dilatation of the biliary ductal.
Correct. There's no biliary duct dilatation. Furthermore, you can also throw out the other diagnosis. There is no liver abscess. Liver is normal in appearance, no population. You can throw out your acute cholecystitis, no thickening or pericholecystic fluid. And the only thing that you can see here is stones in the gallbladder. Therefore, you are left with only one diagnosis, which is acute pancreatitis. This is how the thought process goes, yeah? You history examination, then you confirm your diagnosis from the history examination via your blood test, your other investigation, blood, imaging. Okay, right. Can I ask if anybody have any thoughts on why the hemoglobin is coming down? No need to answer now. Think about it as we go through the seminar. All right, carry on.
Okay, so I have done a modified Glasgow-Imrie score for this patient. So this score used to classify is it severe pancreatitis or mild pancreatitis. So these are the criteria need to be assessed. Oxygen saturation, age, neutrophils, calcium, renal function, enzyme, albumin, and also sugar. So for this patient, only AST is the positive marks for this patient. So this patient score have a score of 1, so indicate mild pancreatitis. So for this Glasgow modified Glasgow-Imrie, if there is a score of 3 or more, indicate severe pancreatitis. So for this patient only score 1, so it is a mild pancreatitis. Okay, next. So for the progression and also management for this patient, at ED, supportive treatment was done to the patient. The patient was kept nearby mouth with IVG of 4 pints over 24 hours. And then pain management, given IV tramadol, stats and also TDS, and also antiemetics, IV Maxolon, and IV pantoprazole, prophylaxis for gastric ulcer for this patient, and then vital sign monitoring hourly. In the at the ward, patient still keep the nearby mouth and also given IV drip 6 pint over 24 hours and continue the gastric prophylaxis gastric ulcer IV pantoprazole pain management and also vital sign monitoring. And then also strict IO charting was done to this patient by inserted CBD. And then ultrasound of HBS was done on day 1 of admission. And then there is a spike of temperature on day 2 of admission, and was sent for septic workup. But for the result at that time still pending. And then the fever was resolved by 2 types of paracetamol. And then she also given IV augmentin on the day 3 of admission. Was started on the day 3 of admission after the fever. Next. So she was discharged on day 5 of admission with medication antibiotic for 1 week, analgesic for 1 week, and also pantoprazole for 2 weeks. And then she was given TCA at SOPD 1 week after to review the blood CNS was taken at the ward, and then to also get date for laparoscopic cholecystectomy. And if there is any jaundice or abdominal pain, fever before the TCA, before the TCA at SOPD, the patient need to go to emergency step. I think that's all from my part.
Okay, thank you. I think that's a nice case which highlights the importance of first understanding what you are dealing with from a history examination, and also highlight how pancreatitis can actually present not the typical way, in an atypical manner. Yeah. All right, carry on.
Okay, next we continue with the first topic is the first topic which is acute pancreatitis. So we will be presented by me, Muhammad Zufar bin Zakaria, and the other part and we'll continue with my partner, which is Muhammad Aziz Bijasni. So the acute pancreatitis, the definition is acute pancreatitis, where it's an acute condition where presenting with abdominal pain and a default of a greater rise in the same level of pancreatic exam, such as amylase or lipase, and or characteristic finding of pancreatic inflation on contrast enhanced CT. So in the division actually is derived from the reverse Atlanta. Reverse Atlanta, is from the reverse Atlanta. So it have two type of acute pancreatitis, where in my condition it is called interstitial edematous pancreatitis, and if in severe it will go to necrotizing pancreatitis, where this is the dangerous one, where it involved with multi-organ failure. So the etiologies of acute pancreatitis, and the scoring of this, where I get smashed, where the first is I is idiopathic, where we idiopathic, where it's about 10 to 12% of cases of the pancreatitis. And to highlight is the common etiologies from this acronym, which is from the gallstone and the alcohol excess, where for both of this is about 30 to 70% of cases, 30 to 70 cases. And for gallstone, if patient have a like intervention was done, where the intervention was done, such as ERCP, where it's about 2 to 6% of the patient who done the ERCP have a risk to get the acute pancreatitis. So this is pathophysiology. So this is like summarize how the acute pancreatitis develop. We go one by one. So like I said before, the two most etiologies that can cause acute pancreatitis, like alcohol and gallstone, where in alcohol there is a increase of metabolites within the pancreas, and this causes the sphincter of other spasm, and also in gallstone, where the migration of the stone from the gallbladder to the common bile duct, where also these both causes lead to the block of the sphincter of Oddi, where when there is a block, the secretion for the pancreas uh cannot go to the duodenum, and it cause the pancreatic secretion back up and increase the pressure within the pancreas. And the other causes there is under mechanism like hyperglycemia or idiopathic, and also there is a causes of hyperglycemia where she's rare, where there is a calcium ion deposition in the bile duct, where it block outflow of the pancreatic secretion. And when there is a backflow of the pancreatic secretion, first is lead to the pressure compress the pancreatic block vessel, and it cause the tissue ischemia within the pancreas, and also the activation of the inactive protease or enzyme in the pancreas is lead to the digestive pancreatic tissue. So when there is eating the destroy the cell tissue in the pancreas, it leads to necrosis of death of the pancreatic cell, where when there is cell death, this lead to a inflammatory response to this condition. So for success because of necrosis, if because you can see the patient may develop pain such as sudden severe excessive pain, where it radiates to the with pattern sign, it radiates to the center of back with the systemic inflammatory response, where patient may have a fever, nausea, or vomiting, and then because inflamed because of the inflammation, more permeable blood vessel leads to fluid into the pancreas, cause the third loss the third loss where patient may have profound dehydration, and then so from the case just now is like atypical features of the acute pancreatitis, where
Zul, sekejap
yes,
can I share my apa ni, my window sekejap for the
Slide.
pathophysiology?
Yes.
Sekejap can I share? Okay. This is what I want you to understand, acute pancreatitis. So duct obstruction, pakai, you can Google this image in the what you call Google Chrome. You can Google this. Basically, pathophysiology of acute pancreatitis. This is the image. Simple, much simpler for you to understand how the process of acute pancreatitis occur. Right? Yang tadi tu busy sikit slide dia. Yeah. It's not that it's not there, it is there, the information is there. Tapi yang ni senang sikit nak ingat ni. Okay. Alright. Remember this, you can actually find it in Google. I think better use that one. Change your slide to this one. Good. Also, the complication of pancreatitis. You have a slide on complication of pancreatitis? Zul? Yes.
Yes, we will have complication of
Yes,
acute
we have.
pancreatitis.
Okay, okay. So carry on with that. Continue.
Hmm. So, before to before we go to complication, let's say uh the
Yeah,
typical
yeah,
clinical features
yeah,
of
yeah.
the
Go.
typical feature of a acute pancreatitis, like patient develop epigastric pain, where epigastric pain where it's sudden or continuous acute onset, dull and shape, uh, dull and sharp, depending on how of the degree of inflammation, where it's irradiates to bed and is relieved by leaning forward and sitting upward. And also, a patient may have aggravated by lying supine, and it may be associated with vomiting and nausea. And however, if a patient have severe attack, patient may have acute abdomen, and also have a patient may develop shock or develop a generalized peritonitis such such as diffuse tenderness, bowel like rigidity. So this is a physical sign if patient of the generalized peritonitis, and the patient may have acute respiratory distress syndrome. So typically, if in my pancreatitis, patient does not have any severe symptom lah. Patient may in physical examination, maybe patient have a fever or tachycardia or tenderness at the epigastric or center of abdomen. However, if the patient have this sign, yeah, it's maybe it may be the severe type of the acute pancreatitis, where the patient pain or the sick looking, or patient have other metastasis. Patient may be confused, tachycardia, or in the tissue, patient have hypotension, and then if it lead to the hemorrhagic state, uh, patient may have a retroperitoneal such as creatinine sign and cholecyst. And as I say, patient may have a bigger tenderness, dilated abdomen, anxiety, and involuntary guarding. So for diagnosis, if you remember the definition before, it formed the revised Atlanta classification of acute pancreatitis, where the diagnosis of acute pancreatitis is need 2 out of 3 of the criteria, where the abdominal pain that suggestive of the acute pancreatitis, and the second is a serum amylase or lipase 3 times of normal upper limit, and the third one is imaging finding of the acute pancreatitis, and it will be presented by next presenter. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Azri. I will continue the presentation with the investigation and also management for acute pancreatitis. So the aim of investigations in acute pancreatitis is to establish the diagnosis and to know the severity and also to identify the etiology of acute pancreatitis. Next. Okay, the first investigation is blood investigation. So we can do assess the serum amylase or serum lipase in acute pancreatitis because these are the enzymes that are produced in the pancreas. So serum amylase may rise within 6 to 12 hours after the onset of symptom and normalize within 3 to 5 days. However, serum lipase it rises within 4 to 8 hours and normalize within 8 to 14 days. So we can see here that and you can also see the picture below that serum lipase has higher half-life and it is suggestive of acute pancreatitis if uh, the serum amylase or lipase uh, is more than the 3 times the upper limit, like what I previous presenter have mentioned. Next. So other investigation also indicated in acute pancreatitis, for example, full blood count. You see if there is any leukocytosis indicative of infection, and then the hematocrit level that may be elevated in acute pancreatitis because in this condition, patient may have dead space fluid loss leading to reduce in intravascular volume. And next one is liver function test to see the bilirubin level and also transaminases. Uh, so this liver enzyme may also be deranged if there is any pathology in the biliary system. Next one is plasma calcium and also phosphate. As been presented earlier, hypercalcemia can also contribute to development of acute pancreatitis. So we want to assess the calcium level, and then plasma lipid also for triglyceride. Increase in triglyceride can also contribute to acute pancreatitis. And next one is fasting blood sugar. Patient may have hyperglycemia because of reduce in insulin production by the pancreas. And the next one is lactate dehydrogenase (LDH). LDH may be elevated in conditions such as pancreatic necrosis because LDH is one of the intracellular enzyme. So when the cell become necrotic, then this enzyme may leak into the blood. Next one is blood urea nitrogen. Blood urea nitrogen is a waste product that usually excreted out by the kidney. However, in acute pancreatitis, one of the complication is acute kidney injury because of hyperperfusion. So when there is damage to the kidney, BUN, blood urea nitrogen may also be elevated. And the next one is ABG, because patient may have acute respiratory distress syndrome because of the acute pancreatitis. And last one is C-reactive protein. Next. Okay, next we move to imaging. Among the modalities that can be done in acute pancreatitis is X-ray, supine abdominal X-ray. So what are the features that can be seen? They are we can either see the sentinel loop sign or the colon cut-off sign. The sentinel loop sign as you can see in the picture, the first picture, it is a short segment of ileus or ileus in the intestine close to an intra-abdominal inflammation process. So the inflammation from the pancreas can spread to the colon, resulting in ileus. So that you can visualize it in the X-ray. And the next one is the colon cut-off sign. Colon cut-off sign, as you can see at the yellow arrow, there is macam the area is not filled with the power gas. So this is also indicative of the inflammation that has spread to the area of spleen fracture from the pancreas. Okay, next. The next one is ultrasound. The purpose we do ultrasound is to look for any calculi in the gallbladder or the bile duct that could contribute to the pathophysiology of acute pancreatitis. Other findings that can also be found in ultrasound is change in the pancreas morphology. The pancreas may be enlarged, and also there is also present of pancreatic fit. You can compare the ultrasound of normal pancreas and also pancreas in acute pancreatitis. So you can see that there is the pancreas, the size is enlarged, and also there is also peripancreatic fluid, so fluid around the pancreas, evidenced by area of hypoaquid area around the pancreas. Okay. The next one is CT scan of the abdomen. So the indication for CT scan is when the clinical and biochemical findings are equivocal or not really suggestive, and also to exclude other intra-abdominal pathology. And MRCP can also be done if CT scan contraindicated. So the first picture of CT scan shows heterogeneous appearance of the pancreas. So the arrow, the yellow arrow, and peripancreatic fat surrounding the arrowhead. So okay, the next picture shows a patient with acute pancreatitis that has homogeneous enhancement in the CT scan, but there is evidence of peripancreatic necrosis. So we can see that at the arrowhead there is an area of hypodense area indicative of the peripancreatic necrosis. Next. So the next one is endoscopy. So urgent ERCP and sphincterotomy should be carried out within 72 hours onset of pain if the pancreatitis is due to gallstone.
Okay, I would like to add something here. What do they mean by gallstone? Does it mean, like in the case that we discussed just now, does the patient need RCP?
Mm, from what I read, if it is the pancreatitis is solely due to the gallstone, then uh, having this procedure is beneficial to the patient.
Okay, so you think you're gonna subject the patient just now that we discussed the case presentation for ERCP?
Mm,
Yes or no?
I think yes, because yes.
Okay, so here I have to clarify for you guys. What it meant by gallstone pancreatitis here is that when you have a patient with pancreatitis, obviously in our part of the world, the most common cause is going to be gallstone because alcohol intake in our country is probably not as high as some other parts of the world. So most likely the cause of pancreatitis is gallstone. And as discussed in the etiology earlier, that gallstone pancreatitis or gallstone itself causes blockage of the duct. Hence, then after that, it will cause the autodigestion of the pancreas itself, leading to pancreatitis. But in most cases, when you do the ultrasound, you don't actually find the stone still blocking the duct. And as I said, the one that we got in this case presentation is the atypical presentation. The typical presentation is that patient is not jaundice, patient just come with epigastric pain relating to the back. And hence, they will not have any evidence of obstruction in the biliary duct. So what they mean by ERCP here as sphincterotomy is when there is still stone that is stuck inside the system in the common bile duct that is blocking, causing biliary obstruction. So patient can have gallstone blocking the pancreatic duct and also the bile duct at the same time. Only when they have caused obstruction of the bile duct that you know that there is a stone there causing obstruction of the bile duct with biliary dilatation, patient is jaundice, then you would subject the patient for ERCP. If the patient comes with just epigastric pain, no biliary derangement, the liver function is absolutely normal, or even just transaminitis, but there is no bilirubin raised, meaning that there is no obstruction in the ducts, and ultrasound also does not show presence of dilated system, patient does not require ERCP, because the ERCP itself can be a cause of pancreatitis. It may make the pancreatitis worsen. So we only suggest this urgent ERCP as sphincterotomy when the stone is still present in the common bile duct and it is causing obstruction. Clear on that?
Thanks.
So in this case, the case that we discussed just now, there is no biliary obstruction, there is no need for you to do ERCP. Okay? All right, carry on.
Okay, thank you. Okay, next we move on to the assessment of severity for acute pancreatitis. So here I provided four classification of criteria. First one is the revised Atlanta classification, followed by Ranson's criteria, let's go English criteria, and also Apache 2 stands for acute physiology and chronic health evaluation. Next. Okay, the first one is reverse Atlanta classification, which classify pancreatitis into mild, moderate, and also severe acute pancreatitis. So in uh, mild acute pancreatitis, there will be no organ failure, no local or systemic complication. Local complication, for example, pancreatic cirrhosis or infected pancreatic necrosis, and systemic complications such as ARDS or AKI. And for moderately severe acute pancreatitis, there is evidence of organ failure. However, it resolves within 48 hours compared to severe acute pancreatitis when there is persistent organ failure, which is more than 48 hours, or multiple organ failure. Okay. The next one is Benson's criteria. So in this criteria, we score patient on two occasions. The first one on the day of admission, and also after that within 48 hours. So the score as you can see in the table, those are the parameters that we score. The age of patient, total weight, blood glucose, LDH, AST, and after 48 hours, we assess for the hematocrit level, blood urine nitrogen, arterial oxygen saturation, serum calcium, base deficit, and sulfate sequestration. So a score of 3 or more indicates severe pancreatitis and a higher rate of mortality.
So you need to remember Atlanta, everyone. So you can forget about all the others, but you must remember Atlanta. Ransom, Glasgow Imbri, Apache, semua tu you tak ingat pun tak apa. But Atlanta you must know. Okay.
Okay, next one is let's go in this criteria. Uh, okay, this criteria is called after 48 hours of the onset of the symptoms, and you can see there all the parameters there. There are 8 parameters, including partial pressure of oxygen, the age of the patient, the white blood cell count, serum calcium, BUN, blood glucose, serum albumin, and also LDH level. And score of 3 or more also indicates severe pancreatitis. So it is likely to be severe pancreatitis. Okay. Next one. Next one is the Apache 2. So this the assessment is also to indicate the severity of patient based on the physiological process in the body. So as you can see in the table, there are 12 parameters that we see, and the higher the score, the worse the prognosis. It can
Oh
also
yeah,
be
this is quite a lot. It's
uh,
difficult to remember, right? But there is application at one time when we use this, but you don't need to remember this. Okay, just to know that it is there. It's called. If you look at the components, almost some of the things coincide with Apache. Glasgow Inri. Some of them coincide with Ransom. Some of them coincide with Atlanta. But actually, Atlanta take all the most important highlights from all these three, Apache, Ransom, and Glasgow, and condense them into Atlanta. So Atlanta is like they're taking the best of the best from the others. So remember Atlanta.
Okay. Okay, next. The next is the management for acute pancreatitis. It is based on the severity of disease. In my pancreatitis, usually only a patient is treated conservatively, in which we give intravenous fluid and monitoring for the patient. And also supportive care, such as pain control with analgesia and also antiemetics. Antibiotics is not indicated in my acute pancreatitis, uh, except when there is any evidence of infection. So the monitoring of vital sign, electrolyte, and serum glucose is uh, also important. And for the nutrition, patient should be given nutritional support either orally if tolerated. If not, for example, patient continuously vomit, then we can use the enteral route such as NG tube, or nasojejunal tube, or parenteral nutrition. In severe pancreatitis, patient may be admitted to the intensive care or high dependency unit, but the principle is still the same. We still need to give fluid resuscitation and also adequate analgesia. So example of analgesia that can be given is in the case that we discussed just now, patient was give IV tramadol. Other option you can give IV fentanyl or hydromorphone. Hydromorphone. Okay, and then in severe pancreatitis, they also need to frequently measure the vital sign, the urine output, and also central venous pressure to ensure that patient receive adequate fluid resuscitation, and also supplemental oxygen. Difficult patient have desaturation, and also antibiotics may be used if there is local or systemic infection. Nutritional support, same as just now, and treat the underlying cause of pancreatitis. So like what Stas mentioned now, ERCP and splenectomy for gallstone pancreatitis. Yes. So for the complication of acute pancreatitis, it can be divided into local and also systemic complication. So I want to highlight in the systemic complication, the ARDS and also the acute kidney injury. So in ARDS, um, in acute pancreatitis, the inflammation from the pancreas can also spread to the lungs because of the anatomical location. It can cause, for example, pancreatic effusion if there is effusion within the lungs, and also ARDS can also be caused by hypoperfusion secondary to third space fluid loss in acute pancreatitis. Same goes with renal failure or AKI. It can also be due to hypoperfusion to the organ that lead to the organ failure. For the local complication, um, among the most common, uh, the thing that I want to highlight is the pseudocyst, pancreatic pseudocyst, and also infected pancreatic nephrosis. Usually, pseudocyst is the formation of cysts within the pancreas itself because of the fluid collection around the pancreas. So the management for pseudocyst, it usually we manage conservatively, no need for intervention unless the cyst become too large until it cause compression. For example, compression to the gastric outlet or compression to the bile duct causing symptom. So in this condition, we do percutaneous drainage of the cyst. And for infected pancreatic cyst, since the pancreas become infected, so we need to give antibiotic to the patient to cover for the infection. And also they may need to drain also the narcotic content of the pancreas. I think that's
Okay. Look at this list of complications. There are many, many systemic and local complications. So, can I share my screen for a second? Okay. I want you to look at this, right? These are the local complications of acute pancreatitis. So this is a sequelae of what can happen to acute pancreatitis. So in the beginning, you get diagnosis of pancreatitis. So pancreatitis is inflammation. So you get either this pathway, which is the inflammatory pathway, ataupun the necrotizing pathway. So when you get in inflammatory pathway, you get interstitial edematous pancreatitis. You get the pancreas being edematous, so inflamed. But on the other hand, you also can get necrotizing. The patient, the inflammation can be so bad that the pancreatic tissue dies, become necrotic. From then on, they follow a different path, but in terms of physiology, almost identical. If you look at what happens the next phase, interstitial edematous pancreatitis, basically the fluid is inside the pancreas only. There's no peripancreatic fluid collection. But as the more fluid being sequestered from the inflamed tissue, now you start to develop acute peripancreatic fluid collection. And what happens in the necrotizing pancreatitis? Same thing. Only initially is necrotizing inside the pancreas, but then that necrotic tissue becomes an acute necrotic collection now. Right? Collection means it's localized to the around the pancreas itself. But this all will occur within or less than 4 weeks. Okay. So within the first week, probably, or less than 1 week, you get either edema, which can also resolve and becomes back to normal, or you can get worse and get necrotizing pancreatitis. But beyond 1 week, they are on the way to become this phase, which is either acute peripancreatic collection or they become acute necrotic collection. But after 4 weeks, now they are being termed as pseudocyst or wall of necrosis. So here it is a collection of this fluid now becomes collected and has got a capsule. For the necrotizing pancreatitis, after 4 weeks, again the same necrotic collection, but now has got a wall, has got a capsule. So as I said, they follow different paths, but the physiology, the pathology of the thing is almost identical. All that depends on the timing. Less than 4 weeks, you call it this. More than 4 weeks, you call it this. Okay, that's for the why we need to have this differentiation. Because if we want to drain pseudocyst or if we want to drain wall of pancreatic necrosis, we can only do it after 4 weeks. We do not do it earlier than that. Okay. When we do the drainage for these procedures, we can actually perform cystogastrostomy, meaning what we do is we puncture through the stomach and drain all this collection into the stomach. So we cannot do that before they have reached 4 weeks or before they have formed a capsule around this collection. Because if we do that before they have formed the capsule, what we would have created at that particular point in time is actually creating a PGU. You've just created a hole in the stomach. Why is it different? Why is having the capsule means you don't create a PGU? Because that capsule have sealed off that space from the rest of the peritoneum. Therefore, by principle of physics, that collection will not drain anywhere else but into the stomach, because the stomach has got the more negative pressure compared to the rest of the abdomen. So then all the collection inside the pseudocyst will go into the stomach, and eventually that space will collapse and it will fibrose and close off by itself. That's the idea. So that's why we need to know this differentiation. All right. Now, okay, I'm going to stop sharing this. Can you go back to the slide of the complications now? Complication slides now. Belum?
Tengah loading.
Okay. So remember my question just now. Why is the hemoglobin going down? And you don't see anything, no PR bleed, right? Why is it going down? Is there anything that you are concerned when you see the hemoglobin going down on a patient with acute pancreatitis? Okay lah, tak boleh nak jawab. It is this one, pseudoaneurysm. Okay. What vessel are we talking about when we talk about the pseudoaneurysm? Which vessel is going to become pseudoaneurysm? What vessel runs near the pancreas? Or on top of, just on top of pancreas? Tell me, splenic artery and splenic vein, they run alongside the pancreas. So when you have inflammation in the pancreas, the splenic vessels, the splenic vein can become thrombosed, but the splenic artery can develop pseudoaneurysm as a result of the inflammation. The inflammatory markers or mediators translocate to the vessel and causes development of pseudoaneurysm, and that can actually bleed intraperitoneally. All right. I think that's about all I want to talk about here. Just to add one more point about the CT scan. The CT scan, as you mentioned, and will only be performed when we suspect there is another diagnosis there that is possible and potential, because we want to make sure that we don't miss anything. With someone who presents to you with epigastric pain, and as you said, when the findings and the clinical findings, the history and the investigation does not tally, other diagnoses should be also considered. Therefore, CT scan may help you to differentiate. Because why? Let's say your patient has got epigastric pain, but actually dealing to PGU. PGU requires operation, whereas acute pancreatitis do not require operation. Therefore, the CT scan will be able to help you. Therefore, you will need to do the CT scan there and then. Other patients where you are very clear on the diagnosis, you do not need a CT scan. The only other time you need a CT scan is when after that 48-hour period that you have resuscitated the patient is still not improving. Now you need to think that this patient has not gone into severe pancreatitis. When the patient is having severe pancreatitis, you need to check whether the patient is developing necrotizing pancreatitis. And how to do so? You have to do CT scan. All right. Now on the CT scan, there's also the Balthazar score. Do you know about that? Balthazar? It is called CT scan, CTSI, CT Severity Index. Okay. Included in that is the Balthazar score. You guys can read about it, how that is used to predict morbidity and mortality. Okay, that's how we use the CT scan to look for necrotizing pancreatitis, and based on that score, it will help to predict morbidity and mortality. Okay, all right. I think that's about it. I want to add on for the acute pancreatitis. Any question? No. Okay, continue to the chronic pancreatitis then.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Hannah. So we are going to talk about chronic pancreatitis. Next slide. So the definition of chronic pancreatitis, according to Bailey and Love, it is a progressive inflammatory disease in which there is irreversible destruction of pancreatic tissue. So the keyword here is irreversible. And then the epidemiology, the incidence is 2 to 10 per 100,000 people. The mean age of onset is at 40 years old. And it is more common in male compared to female with a ratio of 4 to 1. Okay, next slide. So moving on to the etiology. So the first one is recurrent acute pancreatitis or RAP. I'm going to explain about this after this. Next is toxic metabolism. For example, alcoholism, like 60 to 70% of the chronic pancreatitis cases are due to alcoholism. However, only 5 to 10% of people with alcoholism will eventually have chronic pancreatitis. And next is obstructive. For example, stricture or blood occlusion, like stricture formation due to scarring in case of patient like post-acute pancreatitis. So they have scarring, the stricture, and then will develop this chronic pancreatitis. And then congenital. Congenital, like for example, pancreas divisum, it is a birth defect which the ventral and dorsal duct are not joined together. And then others are autoimmune pancreatitis, like autoimmune pancreatitis. Okay, so next I'm going to explain next slide I'm going to explain about the recurrent acute pancreatitis in this hypothesis of SAPE. Okay, so SAPE hypothesis stands for sentinel acute pancreatitis event. So this hypothesis said that basically it is proposed to explain how a single episode of acute pancreatitis could eventually lead to chronic pancreatitis. So this model says that in a setting of a in a case of a patient who are susceptible to this condition, so an initial sentinel episode of acute pancreatitis will sensitize the pancreas into having a recurring or a continual inflammation of the fibrosis through the activation of the immune system. So this initial acute pancreatitis episode attack is called the sentinel event because it signals the beginning of the chronic pancreatitis. So it will alert the physician that we should initiate therapy to prevent this progression into chronic pancreatitis. Okay, I hope you guys got that. Okay, so next slide. So these are the clinical presentation. So sign and symptom, the epigastric pain. So if the if the chronic pancreatitis happen at the head of pancreas, so patient will come with epigastric or right hypochondriac pain. If it is at left side of the pancreas, so patient will come with back pain or left hypochondriac pain. And then the pain may be diffuse but often dull or numbing. And then in nausea, it is common during the attack and patient may also have vomiting, and then it will disturb the exocrine and endocrine function. So in exocrine function, patient might come with steatoria, and then endocrine function, so patient will eventually develop diabetes mellitus, and then weight loss because of malabsorption. Okay, next slide. Okay, so next moving on to the investigation.
So I will continue with the investigation. For chronic pancreatitis, the laboratory test we do for chronic pancreatitis.
Maria, sekejap. Sorry. For the definition tadi, there's an additional point juga. So irreversible destruction of the pancreatic tissue with which actually leads to loss of endocrine and exocrine function. Okay, because that is the final outcome of chronic pancreatitis. Okay, so just add on to that. That's number one. Secondly, if I may share my screen sekejap for the pathophysiology. This all you can get on the internet, guys. But when I look at your slide, does not contain it. There's one here, genetic. Yeah. There's a gene. This is cystic fibrosis. CFTR, cystic fibrosis, and also SPHINX1. SPHINX1, SPHINX1 gene that is involved in basically they have defective transport mechanism. When they have defective transport mechanism, there will be auto activation of the enzymes within the pancreatic tissue, which leads to recurrent inflammation. Okay, So this one you need to add on. The rest you have studied in your slide, the genetic, the hereditary. So yes, there is a CFTR gene, which is part of the cystic fibrosis gene, and the other one is Sphinx1. All right, you can read up on that. All right, okay, carry on.
Kejap
Sorry, the ejaan of Sphinx to SPAINK1, not Sphinx. SPINK Spink1. Okay.
Okay, so we proceed to the investigation divided into laboratory and also imaging. For laboratory, we like to test the pancreatic function. So among the tests are pancreatic secretin stimulation test. However, it is invasive, where we give IV secretin and pancreatic secretions. We give IV secretin, and then we aspirate the pancreatic secretion released in the duodenum and analyze it in a period of 2 hours. So then we measure the concentration of the bicarbonate in the secretions. Normally should be more than 80. We also test the pancreatic endocrine function by doing random blood glucose level or also glucose tolerance test. For exocrine function, we do fecal fat excretion, which we take the fecal sample and measure it over 3 to 5 days while we control the patient's daily fat intake. Um, so normally it should be less than 5 grams per day. Another test for pancreatic exocrine function is fecal elastase. Pancreatic exocrine, if there is pancreatic exocrine insufficiency, the value will be less than 100. However, fecal elastase is less accurate for exocrine function test. Other
Sorry, the fecal fat tu you dapat dari mana ya? 5 grams as far as I know, 87 grams per day.
oh I use up to date. This one from up to date.
Oh, up to date. Oh, what I know, what normally we do is 7 grams.
7.
Tak tahu whether this is something new. Okay, tak apa. I'll double check on that because usually I teach students is 7 grams per day. I think the lab also takes 7 grams, but it's okay. Maybe this is something new lah. Usually it is 7 grams. For many years I've been teaching is 7 grams. So I'm not sure where 5 grams comes from. It's okay. Carry on.
Okay. And then for serum amylase, usually it only rise in early stage. In later, in chronic, usually not anymore because yes, that so yes, next. For uh, for radiological investigation, previously blood. Next lagi. Next. Sorry. Next. Okay. So for radiological investigation, abdominal X-ray is as the presentation may be not specific. So if abdominal X-ray is done, then we can see pancreatic calcification. However, it is rare. But if there is pancreatic calcification, then it is a diagnostic of chronic pancreatitis lah. Yeah. However, since it is rare, so X-ray is actually has little clinical value. And then CT scan, the initial investigation for suspected chronic pancreatitis is the CT scan. So the features that we can see from the CT scan is atrophy of the pancreas, ductal dilatation, and multiple parenchyma and intraductal calcifications. For MRCP, well, MRCP is done to show the pancreatic duct, particularly if the surgery or endoscopic therapy is to be considered. So as it gives more detailed image of the pancreatic duct, it can identify biliary obstruction, and if combined with IV secretin, it may demonstrate pancreatic duct stricture that is not apparent in standard MRCP. So if MRCP with secretin, it has replaced the ERCP as gold standard, as it is not invasive, so it is safer. Back to slides. Sorry. Okay, then next is ERCP. However, as it is invasive, it is reserved for therapy in chronic pancreatitis, such as to remove stone or to put the stent in the pancreatic duct. So it gives the most detailed image of the pancreatic duct. In early stages, we may the ductal changes may be minimal and diagnosis may not be clear. However, in advanced stages, we can see the chain of leak, which is pathognomonic, which is dilated and strictured pancreatic duct containing intraductal stone. Yeah, like the most right picture. And it can also help to determine the type of operation required. Yeah, ERCP also not just diagnostic but also therapeutic. Next. For endoscopic ultrasound, it is useful when the diagnostic when the diagnosis is uncertain, because in endoscopic ultrasound we can also do pancreatic fine needle biopsy, so also to exclude other differentials, and to diagnose using it can also be used to as diagnostic using Rosemont criteria, as in the slides. So if there is criteria, major criteria A, B, and minor criteria. So if we want to diagnose CP from endoscopic ultrasound, then yeah, it needs to have at least one major A feature plus 3 minor features and so on as listed in the
Okay, you don't need to remember this slide sama macam Apache, Ransom, Glasgow, but just to know that Rosemont criteria is all about anatomical abnormality. Okay, and this is how we diagnose chronic pancreatitis using US to detect abnormal anatomy. Okay, that's all. Thank you.
So next. Next lagi. Okay, so for management of the chronic pancreatitis, usually can be managed definitively by treating any reversible underlying cause. So it can be divided into medical or surgical. For medical, we treat the underlying cause such as abstinence from alcohol and tobacco. We alleviate the pain, escalate the analgesia in stepwise fashion, the later ones. We improve the nutritional status, giving low-fat diet, pancreatic enzyme supplements and vitamins, and we treat the diabetes mellitus, lifestyle changes, and oral hypoglycemic agent. Next. The for surgical or endoscopy, the indications, it has a few indications such as the chronic pancreatitis cause obstruction. So endoscopy or surgical treatment used to relieve the obstruction or to deal with complications such as pseudocyst or abscess or due to intractable pain. So among the endoscopic procedure that we may offer, for example, in patients with papillary stenosis, high sphincter pressure, and pancreatic ductal pressure, we may offer endoscopic pancreatic sphincterotomy. Yeah. And then stent placement in pancreatic duct stricture and upstream dilatation, ERCP and ESWL in pancreatic duct stone. In pseudocysts, we may offer percutaneous or transgastric drainage or drainage from endoscopic ultrasound. And endoscopic ultrasound can also be used to give a celiac plexus block for intractable pain. Among the surgical procedure are Begger procedure, Frey or Whipple procedure. So next. So this is Begger procedure. It is to overcome the obstruction and remove the mass lesion, especially when the problem is at the head of the pancreas. So yeah, we reset at the pancreatic head, and we reserve the part of a portion of the pancreatic head, and we attach it to the duodenum. Yeah. Next. For Frey procedure, it is done if the duct is mildly dilated. It is a modification of Berger procedure where the pancreatic neck is not resected, but it is extensively cut out from the head to extent of the disease segment distally. Yeah. And then we attach directly to the jejunum. For Whipple procedure, it is the removal of a segment of the stomach, duodenum, proximal of jejunum, head of pancreas, and common bile duct, and also the gallbladder. Or the other name is pancreatoduodenectomy. So, so after we have removed all the structures, the second step we anastomose the pancreatic and biliary duct proximal to the gastrojejunostomy. Yeah. And then the remaining pancreas we attach to the jejunum there. Yeah. Next. Okay, I think that's all from our presentation.
Okay, I just want to add some more. Sometimes we also add on total pancreatectomy. When the patient has already burned out the entire pancreas and what is left there is no longer functioning. How do you know it's no longer functioning? Patient has got the endocrine insufficiency and exocrine insufficiency. Endocrine insufficiency means patient becomes what happened to the patient? Endocrine insufficiency. Patient becomes diabetic.
Diabetic.
Right? Okay. So what about exocrine insufficiency? What happened to the patient?
Malabsorption.
Malabsorption. And how do they present?
Weight loss, steatoria.
Steatoria. So they have weight loss and steatoria, which is the main, I mean, not the main, like one of the complications or side effects of having chronic pancreatitis. So how do you treat that? I mean, for endocrine insufficiency, you give?
Bagi oral hyperglycemia.
ada block. What does oral antihypoglycemic?
Insulin.
Patient is lacking in insulin. You replace lah insulin. You bagi UHA, dia tak ada insulin. What's going to work? So, how about the endocrine, the exocrine insufficiency? How you treat that? You give pancreatic enzyme replacement therapy. Okay. Pancreatic enzyme, basically you replace the enzyme that has normally been produced by the pancreas. So the patient will have to take the pancreatic enzyme together with their meals. And how do you know you have given enough pancreatic enzyme together with their meals? How do you know? Patient ni kan kalau makan je dia berak cerit, sebab tak absorb the fat. So they become steatotic. So how do you know you have given enough? Everybody is different kan in terms of our enzyme production, in terms of our food intake. So you cannot standardize the dosage of this pancreatic enzyme supplement. So you must understand and devise a way in order to tell the patient, okay, your dose is like this because now, okay, I see that this is indicative that you have now reached the dose for you. I cannot, let's say I cannot prescribe 10 milligram for you and expect 10 milligram for everyone because we all have different diet habits, different diets that we take anyway, different amount of calorie and energy that we take, different contents. So, how do you know? Pancreatic enzyme will help to digest the food. So what happened? If you are able to digest all the food that you have consumed just now, what happened to the food? You have digested, then
will be absorbed by the fat.
Okay, it will be absorbed by the body. Yes, now it can be absorbed. So how do you know it has been absorbed?
Patients start to gain weight. I'm not sure.
No, the diarrhea stops, the steatorrhea stops.
Oh, okay.
You see, the fact that they have steatorrhea because they are lacking in the enzyme to digest those fat in their diet or to digest every other component of their diet. Thus, the big molecules cannot be absorbed by their body, so they come out in their feces material, undigested basically. But when you have replaced enough pancreatic enzyme, they are able to react onto the food stuff that they have just consumed, making them into a smaller molecule. They can be completely absorbed, and hence the most sensitive marker that you can go for is the diarrhea, the steatorrhea. The steatorrhea will stop. The moment you see that, then you know, okay, this is your dose. You have now able to control your steatorrhea. That means whatever you ate just now has already been absorbed. Okay. Any questions, guys? No? Okay. If no, well done. Thank you so much for the session. We end our session with Tasbih Kafara and Surat. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Ms. Azrin.
Thank you, Mr.
Thank you, Mister.